All right, so I'm Dr. Muhilan. I'm a practicing urologist and I'm learning about hormone treatments. So in my practice, I work in a hospital. A lot of my colleagues have lots of doubts about hormone treatment. To be fair, it's what they've been taught and what they've learned. My patients also have some interesting questions, and I decided to take this opportunity to sit with Dr. Neal Rouzier and discuss all those questions with the man who's the expert. So let's start with the big one, right? I'm a guy, I'm on testosterone therapy. So what's a few interesting common questions about testosterone therapy? I started testosterone therapy, I've been on it for 2 years, right?
Good.
If I decide to stop, right, I'm broke, anyway, I get bad info, I decide to quit. Now 2 years ago, I was really miserable. Will I be more miserable now, or would I be about the same miserableness?
You will be the same miserable that you were before.
Okay.
No worse.
No worse, right?
Your levels will go right back down to where they were before. So you will not feel as well as you have been for the 2 years that you've been on it. But just like any medication, when you stop it, then you lose the benefit of that medication. And if you stop the testosterone, you will lose the benefit of it, but you're not going to crash and burn.
So what I mean is, so you got two people, right? So both are miserable. One didn't start testosterone therapy, one did. 2 years down the line, the guy who started stopped. Would they be about the same?
Yes, they're going to be equal.
Okay. So now, I also have young patients, and HCG is cheap because we don't use synthetic. We use the one from horse's urine, which is cheap, right? So my younger patients, I keep them on HCG because they want to preserve testicular size, right? If they stopped HCG, okay, their balls will shrink, correct? Their testes would shrink. Is there any downside to using HCG?
There is no downside to taking HCG long term.
All right.
I have extensive experience in prescribing HCG to men for the last 25 years. Men state that they read where HCG helps preserve testicular size.
Right.
While on testosterone. It does not. Your testicles will still shrink because the negative feedback inhibition effect on the hypothalamus is stronger than any stimulatory effect of the HCG on the testes, such that, in my experience, that I prescribe HCG to the patients because they request it, nobody refills it because they did not see any benefit from it. Okay. If you're on HCG just by itself, yes, you can take that indefinitely. It will help increase spermatogenesis and it will help increase your testosterone levels.
Okay.
But over a period of time, you develop tachyphylaxis and you will lose that effect. At which point in time, then you need to start testosterone.
Okay, so roughly what's your time frame to develop tachyphylaxis?
It's not necessarily a time frame as much as it is an age.
Right, so as you get older...
So the older you are, the less the HCG is efficacious. So if you're under age 40, it works quite well. From 40 to 45, not so well. From 45 to 50, you're maybe getting 25% of the effectiveness as you did from age 30 to 40. Over age 50, I've had only 1 or 2 patients that actually benefited from taking HCG because it did not result in a significant increase or improvement in their testosterone levels, and then they had to switch to, everyone switches and then uses the testosterone.
So almost pointless to keep someone on HCG just for testicular preservation.
It does not.
Does not.
So if you're on testosterone and you take HCG, there's one study to show that it preserves fertility.
Right.
But in my experience, it doesn't. And in my experience, when you take testosterone and HCG, the patients will stop the HCG because they still had testicular shrinkage that did not improve on the HCG, and since the HCG was relatively expensive, they chose not to take it anymore. So I've never had anyone refill it or take it long term when they're on testosterone because it just did not work.
Here, cost is, it's like I say, it's cheap. So far, they're taking it. I do measure testicular size, but I've only been doing it for a couple of years. So I've not seen a change yet, but let me monitor it. But you're right, I have noticed that older patients do not respond that well to HCG.
Sure, the testicles just wear out.
Right. In fertility patients where I've taken patient off testosterone and put on HCG to reverse fertility, there is some improvement.
Sure, and there's studies to show that taking HCG will help improve fertility and help restore sperm function and sperm levels and spermatogenesis much faster than just waiting for it to recover on its own.
Yes.
So if it normally takes 3 months to recover, you'll recover in maybe a month and a half. So it speeds up the recovery.
Period, but you will probably still recover without HCG.
You will, yes.
So those are the fertility issues. Now, the big thing, right? And I've seen a new one by the American Heart Association which debunks this. But a lot of physicians and a lot of my colleagues sincerely believe you take testosterone, you're going to get a heart attack, you're going to get stroke, you're going to get blood clots. Right?
Sure.
I already know the answer to this one, but I'm not you.
You have to look at the medical literature and studies to give you the answer to that.
Right.
They have a confirmation bias. They have a cognitive dissonance against using testosterone, so they're trying to come up with an excuse or a rationalization as to why you should not.
Okay.
There were two studies, the Finkel and Vegan studies, that were both grade D as opposed to grade A randomized controlled trial evidence. Grade D evidence, which was retrospective review of an insurance database, which was worthless. Their statistical analysis has been severely criticized. Both of those studies that show perhaps an increased risk have been severely criticized by many medical academy societies, demanding withdrawal of those studies because of the flawed study. But the journals will not withdraw their studies. So we have thousands of randomized controlled trials showing a decrease in MACE, major adverse cardiac events. Overwhelmingly, there is no study to show harm, except for those two flawed studies that are grade D evidence that you shouldn't hang your hat on. But people want to, and they will use those two studies as, we'll see these studies here. Well, they don't even know if the patients in those studies took it. They were given a prescription for testosterone. We don't know if they took it or not. Maybe their increased risk was because of they didn't take it. All they know is that they got a prescription for it based on an insurance database. But all the randomized controlled trials, when you give it and you make sure that they take it, have shown decreased heart attacks, strokes, morbidity, mortality, blood clots across the board in every study. So if somebody says, oh, it causes this, it causes that, I go, here, read this.
Okay.
I give them a stack of papers this thick where, no, it does not cause MACE. There's a decrease in MACE across the board in every randomized controlled trial.
I guess,
without exception.
Yeah, and I saw two more. One that showed those in the upper third percentile of testosterone levels had a 25% reduction in cardiovascular events.
Sure.
And the other one was increased effort tolerance, I think of the Cleveland Clinic, improve effort tolerance in post-PCI patients with testosterone therapy. So they were looking at replacing testosterone in patients who had cardiovascular events, and the outcomes were good.
Sure. It increases cardiac output. It causes vasodilatation. There's a decrease in angina on stress testing because of the release of nitric oxide. But more importantly, testosterone and estradiol cause a decrease in plaque, intermediate thickness, and a decrease in coronary calcification. Okay. Statins increase coronary calcification in every study. The only drugs that decrease it are estradiol, and testosterone aromatizes into estradiol. You will see shrinkage of plaque in every single outcome study that measures it and looks at it, in addition to decreasing events.
So this correlates with higher testosterone levels are inversely related to cardiovascular events. I mean, higher your testosterone, lower your cardiovascular.
In every study, correct.
Every study.
So in regard to testosterone causes an increase in MACE, all of the meta-analysis, all of the studies show not an increase, but a decrease in MACE across the board. With statin cholesterol medicines, there's a 2 to 3% absolute risk reduction in events. In the testosterone studies, there was a 50 to 100% absolute risk reduction in events. They took men in a secondary study that already had cardiovascular disease and gave them testosterone.
Right.
In 1,000 men, 0 had another event in the 8 years of the study, whereas 50% in the control group of men that had prior cardiovascular disease had further events. What does that mean? That's 100% absolute risk reduction. How much better can you get for that?
Okay.
How in the world is it that they still think that taking testosterone, they don't know? They have a confirmation bias against it. They don't know the literature, and that's why I go, here, read this. Explain this to me.
All right.
So if you go to the PDR, in the PDR it says testosterone may increase events, may. That's because of the Finkel and Vegan study that was reported to them. Well, it's the FDA's responsibility to report any adverse event to the public and to you.
Right.
The European FDA has not done that. They say there's no evidence that testosterone increases the risk for heart attacks, blood clots, or strokes. So in the FDA in Europe, there is no warning. In the United States, they were sort of forced to because they were obliged to advise you if something was reported to them. But the FDA still has not come out and said that there's harm or there's risk. So we are all waiting for this big study, the TRAVERSE study.
Right.
The TRAVERSE study is a randomized controlled trial over a period of 5 years that was adequately powered to see if there was an increased risk of strokes, heart attacks, or blood clots.
Right.
The results of that study were no heart attacks, strokes, or blood clots in individuals that took testosterone. So put it to rest. Here, read this. This is the final FDA study, the most powerful one today. No risk.
So that always brings me to the next question.
Sure.
All my colleagues love this question. So if
Sure.
testosterone is so great, why aren't the cardiologists and endocrine physicians prescribing it?
Well, that's a very
Guidelines.
good question. And your question doesn't really have an answer other than cognitive bias. And other than if a doctor's not up on it, they're down on it. And they're definitely not up on it, so they're going to be down on it. So in the webinars that I give on a monthly basis, one of the participants in the webinars of this group that we have, one of them is an endocrinologist. And I had him present 2 or 3 of the most recent studies where there's a 50 to 100% absolute risk reduction in events in cardiovascular disease and a shrinkage and decrease in plaque,
Right.
decrease in weight, across the board, all benefits. So I said, Dr. Kadami, why is it that your colleagues that are endocrinologists, that are experts in hormones, do not embrace this and jump all over it? His response was, they're stupid. And I said, I'm glad I didn't say it. He says, no, seriously. Look at the data and look at the studies that he presented in the webinar. He says, it's irrefutable. They are well done, randomized controlled trials, multi-center studies published in the most peer-reviewed endocrine journals in JCEM and cardiovascular journals. And how is it that they do not get it or understand it? There's no way to explain it other than cognitive dissonance, confirmation bias, and if a doctor's not up on it, they're down on it. And so they're going to come up with an excuse to support their belief that you should not give it. And that's what you're dealing with is, no, it causes this, it causes that.
Yes.
Show me the study where it does. They can't. Here, I will show you 100 randomized controlled trials and meta-analyses to show that it does not. And the most recent TRAVERSE study says,
It doesn't.
let it go, leave it to rest. If you still believe that it does, it's not evidence-based, you're not scientific, it's your belief structure that needs to be adjusted, but you can't change the religion. They're going to believe it no matter what. It is the way to go, you just have to walk away.
So because I think this was earlier this year or end of last year, the Endocrine Society basically came out against hormone replacement. The Urology Association actually is in favor of it, and there was a rebuttal to it. But that's a problem whenever I ask the endocrine. So a lot of my endocrinologists give me the standard answer. It is not in the guidelines. Okay, and they still believe in reference values rather than clinical symptoms, right?
Sure.
So I keep hitting this wall because supposedly all guidelines are driven by a committee of the best. And since they don't say it, we don't do it.
Yeah, the guidelines are suggestions. It's not case law. And who writes the guidelines? The people that write the guidelines have a bias for whatever they write,
Right.
which is very unfortunate. But the concern still is, well, why is that? Well, the FDA stepped in and as a cost-conserving decision, they said we cannot afford to prescribe testosterone to the whole entire population. So therefore, the FDA steps in and tries to tell you how to practice medicine, which they shouldn't, but they did, but as a cost-cutting, cost-saving measure, because Medicare and insurances would go broke from all the prescriptions for testosterone. So therefore, they restricted the use of it to only people under a level of 300. Dr. Kadame, our endocrinologist with WorldWing, says he participated in that committee. And the reason they picked 300 as their cutoff was because most men have levels greater than 300, and as a result, it's going to restrict the use in 95% of men.
So regardless of symptom, they just take 300 as a cutoff.
Exactly correct. It doesn't mean you can't prescribe it, and you can prescribe it off-label, but you can't make the diagnosis and code it and bill it to insurance. And that is why they restricted it, only for my cost measure. Now, if the FDA steps in and says that, AACE has to follow suit. So they too have to then come up with restrictive guidelines to restrict the use of it for economic reasons, because that's what the FDA mandated them to do. And that's why it is the way that it is. There's no, as Dr. Kadami says, there's no scientific reason behind the level of 300. It is handpicked out of the air. All the other studies use different levels, and before 2014 and the FDA mandate, before 2014 you could prescribe it and make a diagnosis of hypogonadism based on symptoms. It had nothing to do with levels, and the landmark study published in GCM says there is no biological parameter, there's no blood test, there's no level that denotes a deficiency. It's symptoms that denote a deficiency, not a blood test. The FDA steps in 2014 and makes that mandate of a level just out of the air to try to restrict the use of it, but it is not scientific. It's man-made to restrict.
So basically, cost rather than the health of the patient.
You're exactly correct. It's a cost-saving measure.
Okay, that makes, actually I just gave that answer today to someone, that the insurance companies will only pay if it's above this level, they won't pay if it's below that level.
Sure, of course. And that's why Kadami says, well, my colleagues are stupid. They don't want to embrace it. All the studies show benefit. Why don't they embrace it? Because of the FDA mandating that AACE restrict it, and they have to go along with that mandate.
So no choice.
And that's
unless the patient is paying themselves, at which point, go ahead.
Well, if you want to pay for it yourself, you can. You can use it off-label. That's fine, and that's what everyone does. 95% of prescriptions are for off-label use, which means men don't have a diagnosis, means they have a level greater than 300, but they still have symptoms. You can treat them, you just can't make a diagnosis of hypogonadism because by definition, it's levels less than 300.
Okay, right, that makes a lot more sense.
Good.
So that was the biggest question, why aren't cardiologists and endocrine using it, if it's so good. So the next one, this is from my own experience. I'm just asking, we discussed it earlier, the polycythemia. Why polycythemia I do not have to worry about in testosterone therapy?
With all due respect, you're using the term polycythemia.
Right.
What does polycythemia mean? The word. Cythemia is increase in cell count.
Right.
Poly means multiple cells. Erythrocytosis is what you're trying to describe, which is an increase in red blood cells. Some people call it secondary polycythemia, but I can show you 100 papers in the literature that use the term polycythemia for testosterone-induced erythrocytosis.
Okay.
So it is a misnomer, it is a misterm, it is not poly. Polycythemia vera is a harmful blood dyscrasia. Poly is multiple, white cells, red cells, platelets.
All three go up.
All three go up with a cythemia.
Right.
That can cause blood clots. It's not the red blood cell count causing the blood clots, but we're misled to believe that. It's the platelets. In polycythemia vera, you will have platelets 3 and 4 times as high as normal. You're going to have platelet counts over 1 million to 2 million. That's what's causing the blood clots in polycythemia vera.
Okay.
Testosterone does not cause polycythemia vera. It causes a secondary erythrocytosis, which is an increase in red blood cells.
All right.
I just showed you the paper.
Yeah, you did.
The people that live at altitude above 7,500 feet or 3,000 meters. There's 500 million people in the world that live above 3,000 meters that have what is termed excessive erythrocytosis. Excessive erythrocytosis by definition is hemoglobin greater than 20, hematocrit greater than 60. I myself have excessive erythrocytosis.
Okay.
People that live at altitude, those 500 million, do not have an increased risk for blood clots, heart attack, or strokes. We don't phlebotomize them. We don't tell them they have to move to the beach. They don't have to move to sea level because they have an increased risk for blood clots. There's no blood clot risk, even though they have a hemoglobin of 20 and a hematocrit of 60. I showed you the paper as to what the mechanism of action is of that erythrocytosis. The erythrocytosis at altitude, that's high altitude induced, has actually a hormonal mechanism. Brain senses hypoxia. Well, great. But what does the body then do to compensate for the hypoxia? It increases red blood cells to increase red blood cell carrying capacity of oxygen.
Correct.
Great. What is the mechanism by which the bone marrow increases production of the red blood cells? It's an increase in a red blood cell progenitor cell. What stimulates that red blood cell progenitor cell to grow or increase? It's hormonal, and that hormone is testosterone. The high altitude induced erythrocytosis is testosterone induced. The mechanism of action at high altitude for increasing erythrocytosis is the same mechanism of action, testosterone taken at sea level, causing the increase in erythrocytosis.
So from that, we extrapolate that the risk of thrombosis is about the same as someone living at high altitude.
What study, out of hundreds of thousands in meta-analysis, what study showed that polycythemia induced from testosterone or testosterone-induced erythrocytosis caused blood clots?
There are none, as far as I know.
Zero,
Yep.
none, not a one. It is in your urology guidelines not to let the hematocrit go above 54%.
Yes.
Why does it state that? Because that's what the hematology guidelines state.
For polycythemia.
And that's for polycythemia vera. It's not for physiologic induced erythrocytosis. So I showed you those other articles
Right.
recently that the audience is not privy to that are out of the hematology literature. What does the hematology literature suggest the treatment of altitude-induced erythrocytosis, COPD-induced erythrocytosis, and testosterone-induced erythrocytosis? What is the treatment that they recommend for it?
Do nothing.
Nothing. Zero.
Leave the
It's
patient
in the
alone.
hematology literature. Don't treat secondary polycythemia or testosterone-induced erythrocytosis because it has not caused a blood clot in any study in 50 years. But the guidelines say that. The guidelines are wrong, unfortunately. But I also showed you that article that was in the Journal of Urology, written by the urologist that says, we have to stop phlebotomizing people. We have to stop stating or fearing that testosterone-induced erythrocytosis is harmful because it is not in any study, and that's what was in the Urology Journal article. But, like you say, your colleagues are afraid of this. Sure, the urology, endocrine, hematology
all
guidelines
say do
say
the
a
hemosection.
hematocrit greater than 54% requires phlebotomy. Why?
Because they worry about blood clots.
They're worried about blood clots that don't exist in any study that resulted in testosterone-induced erythrocytosis. So if there's no study showing any harm,
Why are we
then
doing
why are we doing it? And that's why the article was written in the Urology Journal about we have to stop doing this because there's no proof or evidence of it. The guidelines are written or taken from the hematology guidelines, which for polycythemia vera,
which you do need to do.
which you don't need to because that's a blood cell dyscrasia. But nevertheless, I can show you and prove to you that, and this is going to be difficult to follow, I hope your colleagues follow this.
All right.
In every single study, high hemoglobin hematocrit in hospitalized patients are associated with a poor outcome. And the poor outcome is from a cardiovascular event.
Right.
Translation, high hemoglobin hematocrit is associated with emphasis on the term associated, with a poor outcome with an increase in events.
Right.
It's not debatable, every study shows it.
Okay.
So, as a result of that, we fear letting the hemoglobin hematocrit go above 54% because in every study, high hemoglobin hematocrit is associated with poor outcomes. Is it the hemoglobin hematocrit that's causing the poor outcome? Well, sure, because in polycythemia vera, high hemoglobin hematocrit causes blood clots.
Okay.
And therefore, we would assume that high hemoglobin hematocrit in the average everyday patient also results in blood clots, heart attacks, and strokes. What did the Traverse study prove? It does not. What about all the meta-analysis? It does not.
Okay.
Well then, why is it that high hemoglobin hematocrit are associated with poor outcome? Is it the hemoglobin hematocrit? No.
Underlying condition.
What causes a regular everyday patient without polycythemia vera to have a higher hemoglobin hematocrit?
Hypoxia.
Hypoxia. From what?
Well,
Sleep apnea. What's the incidence of sleep apnea in the population? A lot.
a lot.
25-50% of men have sleep apnea. What's causing the obstructive sleep apnea?
Metabolic syndrome.
Increase in visceral and thoracic fat from the metabolic syndrome. What does the metabolic syndrome cause? Diabetes, hypertension, and
Truncal obesity.
dyslipidemia. The reason they have poor outcome from cardiovascular events is because of the dysglycemia and the dyslipidemia and the inflammation from the visceral fat related to the insulin resistance diabetes. That's what's driving the disease and the poor outcome, not the high hemoglobin hematocrit.
So
how do you know that? Because in every study when we raise hemoglobin and hematocrit,
patients did better.
they did better. Well, I showed you also, there's a couple recent studies to show that the higher the hemoglobin hematocrit,
Right.
the better the outcomes. The lower the hemoglobin hematocrit, the worse the outcomes. That's just the opposite. The difference is in those studies that showed high hemoglobin hematocrit are associated with harm, they're baseline observation studies. Observation doesn't prove causation, it's interesting, it's hypothesis generating, it's worthless. What I want to know is, does giving testosterone cause harm?
Yes.
I want to know what the outcome is. I want to see an outcome randomized control trial. What study showed harm? None. Great. But in those patients that had higher hemoglobin hematocrits that had better outcomes, they were all on testosterone.
Right. Okay, I got that one.
The higher the level of hemoglobin hematocrit, the better the outcome. Yeah, but I thought high levels were harmful. Those are in baseline studies, but when you give it and raise it, the outcome is even better. So anyone with a high hemoglobin hematocrit at baseline should be on testosterone because they probably have metabolic syndrome,
which you use
that can be
testosterone
treated and reversed by giving them.
testosterone therapy.
But it raises hemoglobin hematocrit. Let it go. It does not cause harm in any study.
So just to recap
It's
this
confusing, isn't it?
one. Okay, let me recap this, see if I got
Please,
it right.
sure.
So let's say someone walks in and first visit, never seen before, and you measure them and they have high hemoglobin and hematocrit. So chances are they have sleep apnea. They have some form of underlying metabolic disorder, whether it's diabetes, dyslipidemia, visceral fat causing inflammation. So they have this underlying condition, triggers the sleep apnea, lot of fat, difficult breathing, hemoglobin and hematocrit go up. If they got admitted to the ICU, they would probably do pretty badly with the high hemoglobin and high hematocrit because of the underlying medical condition.
Absolutely.
Right.
It's the metabolic syndrome, dyslipidemia, cardiovascular disease, inflammation, visceral fat that's driving the poor outcome,
Right.
not the high hemoglobin hematocrit. That's purely an association. That does not prove causation.
So on the same topic, so if I looked at it the other way around, I have a patient who comes in with metabolic syndrome, he's unhealthy, I give him testosterone, I reverse down the metabolic syndrome, that means cut off the visceral fat. As you said, testosterone reduces subcutaneous fat, it drives down visceral fat, estradiol goes up and is beneficial for cardiovascular. Am I right so far?
Yep.
And this patient now has high hemoglobin, high hematocrit, and he got admitted to the ICU for whatever reason. He will probably do significantly better because we have reversed the metabolic syndrome.
Absolutely.
So that's in a nutshell. Did I get it right? That's
Exactly, correct.
Okay.
That person does not need to be phlebotomized as per the current hematology literature. Don't phlebotomize physiologic erythrocytosis. It's not harmful in any study. The TRAVERSE study showed improved, finally, the FDA study, demonstrating no blood clots, heart attacks, or strokes in men that were prescribed testosterone, and 50% of men developed erythrocytosis.
Right.
No adverse
Events.
cardiac event, no MACE at all. Get rid of it. No, it doesn't cause it. It's actually protective against it. Testosterone improves every cardiovascular parameter. Every surrogate marker is improved. HDL goes up, LDL goes down, cholesterol goes down, triglycerides go down.
Agreed.
All the inflammatory
So
markers
I've seen
go down.
all that you just said. I've seen it, including HbA1c, waistline measurements go down. Weight may not change because of bone density and muscle mass, but your waistline tends to drop. That's your abdominal visceral fat. So yeah, I've seen exactly what you said.
You have to give more testosterone to knock that down. And it'll take at least a year before they start to lose visceral fat on testosterone. Most people don't realize that. It's in the literature, it's in the studies. It takes a year. But beyond a year, that's when you really raise your HDL because you're knocking down that visceral fat. Right. It takes at least a year, so you have to be patient with it. But all surrogate numbers, lipids, lipoproteins, apolipoproteins, all cardiovascular risk markers, carbohydrate markers are improved across the board. And that's why there's beneficial effects in outcome studies.
Or if you just look at testosterone without looking at all the associated factors, which confuse the issue.
Yep.
All right.
And if you say, well, that you're not seeing the effect, sorry, you're not using enough of it.
Okay. So
And there's no plateau effect. The studies show there is no plateau effect with testosterone. So the standard dose is given is sort of just a standard dose because that's what we've always done.
right.
But then they did studies where they gave double and triple the dose, and they had double and triple the benefits as far as weight loss, visceral fat,
Wait,
waist
sorry,
circumference,
so
and all lipids.
Are you saying the
parameters.
benefits are linear? That means if I increase the dose this much, I get this much benefit.
Yep, absolutely. It's linear.
I'm going to have a stack of patients queued up after this interview trying to increase their doses.
Are you ready for a question?
Right.
I have on the computer right now a paper that states that testosterone is a pre-hormone. It is not the active hormone.
Okay.
Testosterone is a pre-hormone that converts into the two metabolites. The two metabolites that are responsible for the beneficial effects of testosterone are DHT
Okay.
and estradiol.
Okay.
50% of the benefit is from DHT, 50% of the benefit is from estradiol. All of the cardiac benefits are not due to DHT. DHT is anabolic androgenic. Estradiol is responsible for all of the cardiovascular protective effects. I know you don't like that.
No, I
I
do
know it's
actually.
hard for you to digest because it's in vogue to block estradiol.
Yes. But
I will give you a whole hour presentation on what happens when you give estradiol to men. You ready for the curveball?
right.
It's the testosterone aromatizing into estradiol that's responsible for the cardiovascular protective effects. If you block it with an aromatase inhibitor, in every study you lose those protective effects.
Okay. Sorry. Let's take a small step back because there's estrogen, estradiol, and estrone, right? 3 or 2 actually.
There's only one.
Estradiol.
Correct. The testes will produce estradiol. The ovaries produce estradiol. Testosterone aromatizes in and increases estradiol.
So
Estradiol, once it comes off of the receptor, goes to the liver where it's metabolized into estrone and estriol.
okay.
So there's no organ per se, other than the liver for metabolism, that produces estrone or estriol. It's all estradiol. Go ahead.
Okay. So the estrogen studies, I think that one in women it was shown to be cardioprotective. I not seen it in men. I could have missed it. Is there a study that shows estradiol protective in men?
Well, I only give estradiol to men if they're on testosterone because, as you well know as a urologist, estrogen, the old estrogen that we used was DES, diethylstilbestrol, which caused blood clots. The new estrogen that we give to men with prostate cancer is estradiol. I have treated hundreds of men with cancer outside of their capsule with estradiol because estradiol is androgen deprivation. Androgen deprivation is what you want. Without the estrogen deprivation, and all the
you're
studies
just
show,
causing a negative feedback to block off the testosterone
you're
production.
right, but that's not the main benefit of estradiol. It does work as androgen deprivation therapy, just like LHR antagonists, Casodex and Lupron do. But estradiol or estrogen has an additive effect that is pro-apoptotic to prostate cancer cells, and there is no other medicine that is apoptotic and anti-angiogenic to prostate cancer cells other than estradiol. Every patient, in my belief, that is on androgen deprivation must be on estradiol. 1, to prevent the cardiovascular mortality. 2, to prevent the hot flashes side effects, night sweats, temperature dysregulation that they get from the androgen estrogen deprivation. And you can reverse that with estradiol.
So as far as I know, there are no contraindications of giving estradiol to CA prostate patients.
There are absolutely no contraindications. It's absolutely indicated in every circumstance. The only problem is most urologists don't understand it and will say, well, because I don't use it, I don't know about it, let's not use it because I'm going to ignore my medical literature. Here, read this out of your urology literature on the benefits of estradiol in treating and reversing prostate cancer because of the
Okay, honestly, I got to say, I'm in that group of urologists that like, okay, I've never used it, not going to try it right now.
Here, read this.
I got to go read
You
it.
should be using it because if you don't use it, your patients are suffering miserably with their side effects. What are you doing to treat the side effects of the androgen deprivation and estrogen deprivation? Nothing. Just tell them to tough it out. You tough it out. You see what it's like. You could reverse that and protect that poor outcome by simply giving them estradiol. You will see the lipids unbelievably improve with estradiol. Unbelievably.
Would you see an improvement in glycemic index? I mean, the HbA1c's, sugar as well with estradiol?
Everything improves because the cardiovascular protective effect of testosterone is via aromatization into estradiol.
So that's a good thing.
It's a great thing. In every single solitary study, when you block estrogen with androgen deprivation LHR antagonist,
Right.
or you block estradiol with an aromatase inhibitor, every single solitary study shows harm. Reversal
No.
of the metabolic syndrome, you'll get the metabolic syndrome, you get dyslipidemia, you get dysglycemia. Why would you want to cause that? And you can simply reverse it with estradiol. Abraham Morgentaler is like the world's leading researcher, publisher, writer on testosterone. His partner, Abdul Traish, they have written many articles on the harmful effects of aromatase inhibitors in blocking estrogen in men. They also have written many studies on the harmful effects of blocking DHT with the 5-alpha reductase inhibitors.
Actually, I've read that one on the DHT, so the DHT effect. So now the drug companies push it, and patients like it because they get told, take this drug, your prostate will shrink, you will skip surgery.
I've taken hundreds of patients, if not thousands of patients, off of their finasteride, dutasteride, and none of them noticed any worsening or change. I say, stop it, start it, stop it, start it. Nobody notices any change when they stop it. Well, then stop it. Here, let me show you what finasteride, dutasteride does for Alzheimer's. Let me show you what it does for metabolic syndrome.
It makes it all worse.
Yeah, absolutely it does.
So,
And yet we don't know or realize what the harm that we're causing by using these hormone blockers.
So strangely, this bit of information did not come from my urology colleagues. It came from bodybuilders. So the bodybuilders and the hormone guys who are not urologists, they're not endocrinologists, they are big on this topic, and they put up the literature on why you should not use 5-ARIs for this.
If you go to any gym, you will talk to everyone in the gym, and every bodybuilder in the gym is on an anastrozole aromatase inhibitor. Why?
They believe it cuts down the fat, gives them the...
Yeah, they believe. Well, if you go back 30 or 40 years and you read this book called The Underground Book of Steroids, in the Underground Book of Steroids, they advise the bodybuilders that cycle on and off. They cycle on 8 weeks, off 8 weeks, on 8 weeks, off 8 weeks. And when they're off, they want to try to stimulate their testes to recover quicker to produce testosterone when they're off cycle. They try to convince the doctors to prescribe anastrozole aromatase inhibitors to them. So they in turn tell the doctor, oh, I've got gynecomastia, oh,
fluid retention.
I get emotional when I see kitty cats on television. It tells them to say those symptoms to the doctor in order to get a prescription for anastrozole. So that's why it's popular with the bodybuilders, because they want to increase their own testosterone, because you're not converting into estradiol. You're raising your own testosterone level by blocking the conversion into estradiol. But when you do that, you adversely affect bone, you adversely affect lipids, you adversely affect all of your lipid parameters, and you make your risk for cardiovascular disease much worse.
Vasculitis is much worse.
And they don't understand that. So there's this famous paper published in the New England Journal of Medicine in 2013 by Finkelstein et al. And in Finkelstein's study, what they did was they gave testosterone to 2 groups.
Right.
And they gave one group placebo, and they gave the other group anastrozole to block estradiol.
Okay.
In the group that got anastrozole to block estradiol, increase in lipids, cholesterol, LDL, decrease suppression of HDL, increase in visceral fat, increase in subcutaneous fat, increase in heart disease. And those that did not take anastrozole, that let the estradiol go up,
Nothing.
They felt great. The other part of the Finkelstein study, which is what I saved for last, was in Finkelstein's study, when they gave anastrozole, they get
that sucks as a guy.
erectile dysfunction and loss of libido. So for years I tried to argue with the men that came in requesting, and it's always young men that are bodybuilders, that were requesting anastrozole. And I go, here, read it in Finkelstein's study, erectile dysfunction. So when you want to increase erectile dysfunction, take the anastrozole. Here's the paper on it. I've never had anyone come back and ask for a refill.
What a shock that one is.
Amazing, isn't it?
Yeah.
I have taken hundreds of patients off of anastrozole
And they come back.
the erectile dysfunction resolves. I hope that was fun.
No, it was, and just freaked me out a little bit there. So on a similar topic, so not me, by the way, just to be clear. Coming out of Europe, there's a group of physicians who practice giving progesterone to patients. I already know why not, but it is very popular here in Malaysia to give progesterone to male patients. And I think that was partly due to this, actually it did come from the States on estrogen dominance theory, which started with women and somehow has migrated to men as well, to give progesterone to counter the effects of estrogen.
So I didn't know estrogen was bad.
So this, I think, was...
You threw out the term estrogen dominance.
Yes.
Show me one study in the medical literature that uses the term estrogen dominance.
It's not there. It came out from...
It is not there at all. It's
family
purely
practitioner.
it's purely man-made.
Yes.
Estrogen dominance is not estrogen dominance. Estrogen dominance is insulin resistance. How do
Yes.
I treat estrogen dominance?
Testosterone.
With estrogen and testosterone.
So you give estradiol with testosterone.
You will see lipids improve tremendously when you give estradiol. So I explained to you that 50% of the benefit of testosterone is in the conversion to DHT, 50% is in the aromatization into estradiol.
Correct.
There's cardiovascular protective effects of it, but you're also probably not aware that it's the estradiol that allows the glucose to get into the muscle cell where it's metabolized. When you block that estradiol with an anastrozole, an aromatase inhibitor,
Right.
metabolic syndrome increases, blood sugar increases, and the glucose cannot get into the cell.
So you become diabetic.
So you become insulin resistant and then diabetic as a result of it. Well, you don't want that. You want the other, and that's the estradiol is important. That's why we give estradiol in addition to giving them testosterone, because of the cardioprotective effects of it. But also, there's improvement in visceral fat. There's improvement in weight loss. There's improvement in sexual function. In Finkelstein's paper, and in other studies, when you block the estradiol, it affects erectile function and libido. When you add back the estrogen, that improves libido, sexual function, and
Yes.
erectile quality. It's really the estradiol that's responsible for that. We think it's just the DHT. We don't realize it's the estradiol, but it is. But everyone is still thinking in that thought process of, oh, they've got estrogen dominance because high levels of estradiol in men are associated with, it's not causative, associated with an increased risk for cardiovascular disease, diabetes. Well, that's true. But what's driving the cardiovascular disease and diabetes? The estradiol?
No, the metabolic syndrome.
When you give estradiol, it reverses that. Yes, but baseline high levels are associated with harm. So in every study in women and men, high levels of estradiol at baseline are associated with harm. Where's the estradiol come from? The visceral fat.
Okay.
Visceral fat doesn't produce estradiol. Visceral fat produces estrone that converts back upstream into estradiol,
Okay.
and will raise it in the studies that are baseline studies. So everyone has in their thought process that high levels are harmful, and we know in women that you oppose estrogen with progesterone, so therefore we need to oppose estrogen in men with progesterone too.
So,
I will show you the 3 studies in JCEM, or Bible of Endocrinology. Progesterone is extremely inflammatory and harmful to men.
agreed.
Then why do they say it? They don't understand it, and they think, oh, you got estrogen dominance, you got the belly fat, and so we're going to give you progesterone. In no study do you give progesterone. It actually increases the inflammation and the inflammatory cytokines produced by the visceral fat. It's harmful in every study. So in this weekend on part 2, I'm going to show you the papers on progesterone in men. One of the papers on progesterone in men shows that it's very successful and has been used for years in prisons and jail as saltpeter because it dramatically decreases libido, sexual function.
Okay, so I'm going to move off men for a little while because we covered major controversies. So the next one, the endocrine love to bring this up, is in women. So 2 things, right? So the new guidelines say don't give progesterone, don't give hormone replacement above 60 for women because of the loss of benefit for cardiovascular.
Oh, absolutely. Every progestin, norethindrone, medroxyprogesterone acetate, negates all of estrogen's benefits. But the endocrine world cannot differentiate or know the difference between a progestin and natural progesterone.
Right. So
They do not understand it, they don't get it. Yeah, but they're hormone experts. No, they're not, sorry.
okay. So just to be clear, what Dr. Neal said is of benefit is the bioidentical hormone. The study was referring to the synthetic hormone.
Of course.
All right. So
Don't
that's number one.
extrapolate them to be the same, and doctors do because they don't understand the difference.
Right. So don't give synthetics. Follow the guidelines. Don't give synthetics above 60.
But you can give progesterone until they're 110.
Right. And that's a bioidentical hormone. It's oral or sublingual, depending when you take it. Just to be clear, because I'm talking to the audience, I just want to be clear on that. The second thing is endocrinologists love the Women's Health Initiative study. There have been 2 papers out on it, again, showing why it's flawed. But the WHI in brief did not show benefits of hormone replacement. In fact, it showed adverse events, but it was a poorly constructed study.
Absolutely.
But it's still the reference study that a lot of people quote.
I absolutely agree with their concepts of not using hormones in women over age 63 because of the risk for breast cancer, heart attacks, and strokes.
Okay.
Don't use Prem-Pro because there's a risk of heart attacks and strokes and blood clots and breast cancer with that.
Sorry, one second. What Dr. Neal is talking about is synthetics, because the public might see it rather than doctors. I'm just explaining the difference.
But don't apply that to bioidentical estradiol and progesterone.
Okay.
In 50 years of studies, there is no harm to estradiol and progesterone. In any single study to date, it's always Prem-Pro, the synthetic hormones. And don't extrapolate them to be the same. The endocrine world does. They don't understand it. They don't get it. Yes, but they're hormone experts. They should know it. They don't. Sorry.
Because, okay, part of the reason, so this brings us to the next thing. So endocrine world says bioidentical hormones not regulated. The FDA does not regulate it. Nobody regulates it.
Read this on what estradiol and progesterone do. There is no harm. Don't come back with they're not regulated. There's no harm in either the compounded or the commercial estradiol or progesterone, the bioidentical hormones.
Okay.
They don't know, they don't understand it, and they never will. Walk away.
So go back one step there. You said you agree with the WHI study, right?
I agree with the fact that Prem-Pro caused harm.
Right.
I agree you should not give Prem-Pro.
But when they re-looked at the WHI, by the way, they showed enough flaws, and when they broke it down, they did show benefit.
Terrible flaws. Yeah, there's benefits, but there's still a risk for breast cancer with Provera. But with estrogen alone, if you even look at the current endocrine guidelines, the endocrine guidelines say, well, if it's estrogen alone without the progestin, it's actually beneficial.
True.
There's no risk of anything with it, and the woman can continue it forever if she desires to do that.
Another big argument that I have, so it's very interesting, the 2 common morbidities that women die of are osteoporotic fractures and recurrent urinary tract infections. So my big argument to use estrogen is for urinary tract infections, and estrogen and progesterone bioidentical to prevent osteoporosis. I usually throw in a bit of testosterone as well, much lower doses than for men. And do you see any flaw in this?
There's no flaw. You can reverse urogenital atrophy. You can protect against osteoporosis and heart disease with estrogen, progesterone, and testosterone.
Okay, the next thing they come up with, should you screen? So women come to me and say, look, doc, I'm taking this, I'm taking bioidentical, and I do tell them, 50 years of literature, I attended your course last year. No evidence of cancer, no evidence of breast cancer, no evidence of uterine cancer, blah, blah, blah. They still want to be screened.
That's okay to be screened.
So you would do a breast, a pap smear.
Sure.
And would you measure uterine thickness?
No, not unless they're bleeding. If they're bleeding, yes. If they're not bleeding, then you don't need to.
All right. So a woman is on 3 things, right? Progesterone, estrogen, testosterone. If someone comes, she looks fit, she's healthy, heart's good, everything's good. Only the bones look, she's -1, -2. Is there any downside to giving her purely testosterone? Because she's asymptomatic on every other score.
I don't want to confuse you, but yes. And the reason is because, and I know you're not going to believe this,
Okay.
testosterone in men aromatizes into estradiol and raises it. Testosterone in women does not.
So they lose the estradiol effect.
Their estradiol will go to 0, and I've got hundreds of patients with breast cancer that I treat just with testosterone that have estradiol levels of 0 to prove that. And the literature now comes out with studies to show that.
So women, you have to use all 3?
Yes. Yep.
Right.
You should.
Okay. Okay, last one just for the guys. So all my patients, so 1 milligram of finasteride and 1 milligram minoxidil. 1 milligram finasteride, it's a very low dose. They seem to be fine, but I am blocking BHT. I know about the saturation effect on the hair, but with minoxidil and this thing, they retain their hair.
Sure.
Would you take off the DHT if you were treating them?
Yes.
You take off the finasteride.
Yes, I would.
So you just keep them on minoxidil.
Yes.
Even though it's just such a low
long
dose.
explanation. I'll explain it to you afterwards. But giving them testosterone does not increase hair loss. But giving them finasteride and blocking the DHT will increase hair growth. Again, it's due to the saturation effect, saturation model. Same with prostate cancer.
Right.
So you have to understand the saturation model to understand that giving testosterone does not increase hair loss. Giving testosterone does also not increase prostate cancer because of the saturation model, the saturation effect.
So you reach a certain level, you're maxed out, every receptor is blocked.
200 or greater, total testosterone 200 or greater is the saturation level.
So giving anything above that makes no difference.
It makes no difference because of
all the receptors are blocked.
Receptor sites are already actually saturated.
Okay, so giving the 5-ARI not going to make a difference. So I might as well just keep you on minoxidil. Dr. Neal, thank you so much. You answered a lot of my questions, and I'm going to get this video edited and shipped out to my colleagues.
I hope this was a good introduction as well as exposure to the benefits of hormone replacement, and that we address some of the issues, controversies, questions, concerns that people have and carry because of their cognitive dissonance or confirmation bias. But you have to use the medical literature and studies to support what it is you do and why you do what you do, and that's why I teach what I do.